Good evening, everyone, and welcome to tonight's webinar. We are pleased to host tonight with the Cancer Standards Surgery Program to host with the National Accreditation Program for Breast Centers, a webinar on the technical standards for breast cancer surgery, utilizing operative standards in a changing clinical landscape. Next slide, please. My name is Makisha Miggins, and I'll be your moderator tonight. But before we begin, a few logistics for your consideration. All participants for their webinar are muted. And if you have any questions or comments or need any technical support, we ask you to please use the question panel as directed here on with the green arrow. And then also be advised that after the webinar, you will receive an email for your evaluation to be completed. Next slide, please. For tonight's webinar, there's one PRA category credit available, and you must claim your CME by November 11th, 2023. Next slide, please. Please review our disclosure information. Next slide. Thank you. Next slide, please. The program objectives. Tonight's forum, we will discuss evidence-based operative standards for the performance of breast cancer surgery, including partial mastectomy, total mastectomy, axillary lymphadenectomy, and sentinel lymphadenectomy, as outlined in the Operative Standards for Cancer Surgery, Volume 1. This will include a review of technical standards and the rationale supporting these recommendations. And from this discussion, we hope that you will gain insights into the clinical management of breast cancer and applicable controversies. At the completion of the activity, participants should be able to recognize the key operative standards for the performance of partial mastectomy, total mastectomy, and axillary lymphadenectomy, as well as sentinel lymphadenectomy, endorsed by the American College of Surgeons Cancer Research Program and Cancer Surgery Standards Program. Illustrate evidence-based rationale for these standards and how they impact patient outcomes. Demonstrate competence in the description of technical aspects of the operative standards, and apply insight into contemporary breast cancer management, including clinical controversies. Next slide, please. The speakers for today, we will have Dr. Puneet Singh and Dr. Lindsay Kilgore, who will facilitate case discussions with Dr. Kelly Hunt and Dr. Catherine Yao. At the conclusion, there will be a potential opportunity for questions and answers with the panel discussants. Next slide, please. Research has shown that improvements in compliance with evidence-based guidelines may result in reduced healthcare costs, reduced hospital length of stay and complications, improved long-term outcomes, and increased patient satisfaction. Next slide, please. The Commission on Cancer recently adopted 6 recommendations from the Operative Standards for Cancer Surgery Manuals into their standards for COC accreditation. As shown here, standards 5.3 through 5.8 include 2 standards for breast cancer surgery, 1 for melanoma wide local excision, 1 for colectomy, 1 for total mesorectal excision, and 1 for pulmonary resection. Each COC operative standard describes critical components of the cancer operation based on associated evidence showing improved patient outcomes. Standards 5.3 through 5.6 have documentation requirements for operative reports, and standards 5.7 and 5.8 have documentation requirements for pathology reports using the College of American Pathology protocols. The full COC 2020 Standards Manual is available online for anyone looking for more detailed information. Next slide, please. Here we can see the breast cancer operative standards and their critical elements. For a partial mastectomy, axillary lymphadenectomy, and sentinel lymphadenectomy. Today, we'd like to first draw your attention to sentinel lymphadenectomy and identification of all sentinel lymph nodes. Next slide, please. The recommendation is for all sentinel nodes must be identified, removed, and subjected to pathologic analysis to ensure that sentinel node mapping and sentinel lymphadenectomy provide accurate information for breast cancer staging. Sentinel nodes are defined by the presence of a tracer, their radioactive tracer and/or a colored dye that has been previously injected into the affected breast, or by the presence of a dominant palpable lymph node identified by the operating surgeon. Here in the illustration here in the photo, you can see the blue lymphatic channels and the lymph node present. This data has been reviewed by randomized multi-center prospective trials, and the group strongly endorses this recommendation. Next slide, please. Operative Standards in the ACS cancer programs and Commission on Cancer have recommended we integrated Operative Standards into accreditation process in 2020. The breast standards went live in 2023 with the plans for site visits to begin in 2024. This is for COC Standard 5.3, sentinel lymph node biopsy, and COC Standard 5.4, axillary lymphadenectomy. The NAPBC in 2024 will have to demonstrate compliance with the COC Standards 5.3 and 5.4 as well. In addition, Standard 5.9 for surgical care. Next slide, please. Optimal resources for breast cancer 2024 standards. For more information, there's an optimal resource for breast cancer standards booklet that the NAPBC has available. These standards will go into effect in January 2024, but site visits will begin in January 2025. Dr. Yao, would you like to add anything here about this?
Yes, I just want to provide some clarification because we get lots of questions about this. These operative standards will be listed under Standard 5.9 in our new standard manual, which is coming out in January of 2024. Seeing that a high percentage of NAPBC programs are also COC accredited programs, a lot of you will already be doing this by the time that our new standards come out. But just to clarify, if you are a recurring site or a site undergoing reaccreditation, even though the standards are being launched in 2024, you're not going to be reviewed on them until 2025. If you are a new site and you have not undergone NAPBC accreditation, and you decide to undergo accreditation and have a site review in 2024, you can choose to be reviewed on 2018 standards or 2024 standards. So I just wanted to clarify that because, again, we get lots of questions about that. Thank you.
Thank you, Dr. Yao. Next slide, please. So for sentinel node biopsy for breast cancer, of course, as we discussed, critical components of the operation is the injection of a radioactive or colored dye and identifying the lymph nodes at the end of the lymphatic channel or any palpable suspicious nodes or any clipped nodes. For documentation, though, it is required that you identify whether this operation is performed for curative intent, what tracers were used, if this is occurring in the upfront or neoadjuvant setting, that all removal of all sentinel nodes must be documented, as well as removal of all clipped nodes if applicable. And again, the timeline for implementations began in 2022 with compliance being checked in 2023 for site visits that will occur during this time, and we recommend a 70% compliance is what is required. Next slide, please. Similarly, for axillary lymph node dissection, the operation, of course, must be detailed, and the documentation that is included, again, is the curative intent, the resection boundaries, preservation of vasculature, and if any nodes from level 3 were removed. The timeline for implementation is the same as with sentinel lymph node biopsy, with 70% compliance expected to be achieved in 2024. Thank you. Next slide, please. We'll now move on to our first case presentation by Dr. Kilgore with discussant Dr. Yao. Thank you.
Yes, thank you for having us. So this first case is about the technical standards for mastectomy as well as axillary lymphadenectomy. So if we can go to our first slide, please. So this is a case presentation. Bear with us as we have a lot of information to cover as we go through it, but we're happy to answer any questions at the end. So this is a 52-year-old female who presented after self-palpating a right breast mass. Her medical history is otherwise insignificant, but her family history is significant for breast cancer in her mother at the age of 48, her sister at the age of 50, and ovarian cancer in her grandmother in her 50s. On physical exam, her BMI was 22. She had a 38D bra size as well as grade 2 ptosis, but you palpated a 5.5 centimeter ill-defined, firm, yet mobile mass in the right upper outer quadrant with associated skin retraction. You also, during your axillary exam, palpated one large mobile right axillary lymph node, which was not matted, and you did not appreciate any supra or infraclavicular adenopathy. Next. On imaging, these are pictures of her diagnostic mammogram and ultrasound for your reference. Next slide. So because of this imaging and your clinical exam finding, you pursued ultrasound-guided biopsies of the breast as well as the axillary lymph node. The breast demonstrated invasive ductal carcinoma, which was hormone positive, HER2 new negative, grade 2 with a Ki67 of 15%, and the axillary lymph node biopsy was positive for metastatic mammary carcinoma. Next slide. So, Dr. Yao, now that you have this information and the patient is sitting in your clinic, how would you counsel this patient regarding her surgical options?
So, Lindsay, you chose the type of case that I hate the most. So thank you very much.
You're welcome. I know everyone's from it.
Younger woman, hormone receptor positive, HER2 negative cancer, larger tumor, positive lymph node. Right now, if you were to go to the operating room, she would need to have a mastectomy and she would need to have an axillary lymph node dissection, so a modified radical mastectomy. You have options for different types of mastectomy. Nipple sparing mastectomy might be a little tricky in her case because her tumor is fairly large and it looks like it's causing some skin retraction, and I get a little nervous doing nipple sparing with these larger tumors in the upper outer quadrant that I may not be able to get all of the disease out or get a negative margin, and we can talk about further testing to evaluate that. But right now that would be the surgical approach, and I think we'll get into other options for her if she really doesn't want a mastectomy.
Yes, next bullet, please. Those are great. So would you recommend any additional imaging for this patient prior to proceeding with your surgical resection, particularly MRI?
So I think if we are considering a nipple sparing, I probably would order an MRI to determine if there's tumor extending down to the nipple. My rule is if anything is within a centimeter of the nipple areolar complex, I'm not very excited to do nipple sparing. I think for this lady as well, because she does have some possible skin retraction, a larger tumor in the upper outer quadrant, I might like to get a better sense of the extent of tumor, and I might have a better chance explaining to her why I may not be comfortable doing a nipple sparing in her case.
Great, next bullet. And then are there any other tests based on her history and presentation that you would consider getting in her as well?
So she does have very suspicious family history. So I would recommend genetic testing that can be expedited if possible. At my institution, our genetic counselors and geneticists are very kind to see these patients within a week so that we can facilitate the genetic testing so we can use it for surgical decisions. I think I would like to get a sense of how many lymph nodes are suspicious in her axilla, and I think she had an axillary ultrasound with a biopsy. I don't know if they specified the number of lymph nodes that look suspicious. And further, discussions with her about her thoughts about surgery, her comfort level with mastectomy, all of these sorts of things would help facilitate those discussions.
Okay, next. And would your treatment recommendations change to recommend neoadjuvant chemotherapy prior to surgical resection at all? And if so, why?
So in this patient who is strongly hormone receptor positive, she has a grade 2 tumor. She is HER2 negative. I think the likelihood that she's going to have a great response to neoadjuvant treatment is going to be low. It's probably going to be on the order of 10 to 15% chance of a pathologic complete response, and that would be on a very good day. A test that you could use to determine possible response would be an oncotype. And there have been several studies looking at oncotype scores and how they associate with the response to neoadjuvant treatment.
Great.
For this patient, a reason to maybe pursue a neoadjuvant route in this patient is she's younger, and she may decide that she wants a bilateral mastectomy. She may decide that with the mastectomy she wants reconstruction. There's genetic testing that needs to be done. There's just a lot of decisions and consults that need to happen. And sometimes by the time you get through all of those, you get the patient on the OR schedule, you actually do the surgery. There's a lot of time that passes. And I think in some of these scenarios, if the medical oncologists are confident in the type of chemotherapy that they want to give her, that sometimes it's easier to do the treatment first, the systemic treatment, and then plan the surgery for afterwards.
Great, next slide. Well, we got all the things that you wanted. And so the MRI showed the known right breast locally advanced cancer, confirming with the ultrasound that also demonstrated 4 suspicious level 1s, but no suspicious level 2, 3, or IM nodes. We got the expedited genetic testing, and it did reveal a pathogenic BRCA1 mutation. And then the oncotype to help you in your decision making was 12. So after multidisciplinary discussion, because we know that our breast cancer care depends on all of the disciplines, we decided to go ahead and proceed with surgery first. Next slide. So now that you know that this patient has a BRCA1 mutation, how would this change your discussion with her with regards to her surgical planning?
So having a BRCA1 mutation increases her risk of getting a second breast cancer. Her risk is probably going to hover around 20 to 25% at 10 years. So I would discuss with her a bilateral mastectomy.
Okay, next bullet. So you then would proceed with a bilateral mastectomy. Is there a specific type that you would now, based on the information given, elect to proceed with?
I am comfortable doing nipple-sparing mastectomies in BRCA carriers who have cancer. Now, her cancer is quite advanced. She has quite a big burden of disease, so I might lean a little bit more towards just a skin-sparing technique. Our plastic surgeons have been using a WISE pattern for these women who have a little bit larger breasts, and that has worked out very well. We don't save the nipple in that case, but it has resulted in a very favorable cosmetic result.
Okay, next bullet. So when we talk about the operative standard for mastectomy, as Dr. Miggins briefly mentioned, the key elements for mastectomy are your incision placement, identifying the boundaries of your mastectomy, how you elevate your mastectomy flap, whether or not you excise the pectoralis major muscle, and then preventing a seroma and making sure that you place a drain. Next. So when we talk about incision placement, as Dr. Yao mentioned, there's different ways that you can do your mastectomy. When you perform a total mastectomy, there's different incisions that can be used, especially when dealing with the excess lateral tissue that can be present. When dealing with skin-sparing mastectomies, you can do different incisions around the nipple and areolar complex, whether it's WISE pattern, radial, or ellipse. And so these are just some of the demonstrations of that. Then on the far right side, you will notice the nipple-sparing mastectomies, where most commonly you'll see either inframammary or a radial incision, although crescent shapes and others can be used as well. Next. So when we talk about the boundaries of the mastectomy, the superior boundary is the second rib, inferior is the rectus sheath, medial is the lateral border of the sternum, and lateral is the latissimus dorsi. You must make sure that you also include the tail of the breast that extends into the axilla, and then you must document whether or not you remove the pectoralis fascia, and making sure to preserve, though, the serratus and the rectus fascia during your dissection. Next. When we talk about mastectomy flap elevation, I think this is something also that really just depends on the patient's body habitus because of their subcutaneous thickness of their tissue that can vary from patient to patient. But whether or not you use sharp dissection or electrocautery devices, it doesn't matter. When we talk about excising pectoralis major muscle, you only want to do that if it's going to help you achieve negative surgical margins. And as I mentioned earlier, you definitely want to make sure to place drains to help prevent seromas from accumulating so that it doesn't delay any other additional treatments. Next. So Dr. Yao, in this patient, we just performed our mastectomy, but now we've got to deal with those lymph nodes. So how do you perform your standard axillary lymph node dissection?
So I start medially and identify the pectoralis muscle because I think that's a pretty easy landmark to identify. So I dissect a little bit along the pectoralis muscle inferiorly, identify that sort of fatty axillary fat, and then dissect more laterally and dissect down to the axillary vein to identify the superior aspect of the dissection. And then from the axillary vein, I will identify the thoracodorsal. There's always a small little vein right on top of the thoracodorsal that you're always afraid to take because you're worried it's a thoracodorsal, but you can remove it. And you can name that vein after your resident too, or your fellow. That's what we always do. And then I dissect medially to identify the long thoracic nerve running along the chest wall. This nerve is sometimes a little tricky to find. It's usually in the fat. It's not usually right along the chest wall. So you have to be careful if you're retracting. You might be retracting the nerve outward. And then remove all the tissue in between the two nerves. And you have to be careful in people who are very skinny because sometimes when you're removing that tissue between the two nerves, you'll pull up on the thoracodorsal bundle and you could go right through it or get very close to it. I try my best to preserve the intercostio brachial sensory nerves. I have to admit I don't always preserve them. Sometimes it's difficult, especially in somebody who's got multiple positive nodes or palpable lymph nodes. And I do use the ligature device for my axillary lymph node dissections. I don't know if it's actually been shown to help decrease seroma, but it does help with the dissection, decrease the rate of bleeding, and allows me just to see the structures more clearly. And I do feel it helps, especially in maybe more obese patients that are more prone to problems.
Excellent. Next. So when you're counseling your patients on the risks of an axillary lymph node dissection, what do you particularly say to warn them of these risks, but also not to instill too much fear in them for the operation that you're comfortable doing?
So the biggest risk is lymphedema. And I do explain that the studies have shown risks can vary from 15 to 20% of patients who have axillary lymph nodes removed. If patients are undergoing radiation in addition to the axillary lymph node dissection, that's going to increase the risk of lymphedema. We have all of our patients see our physical therapists for measurements and counseling prior to the axillary node surgery and then to see them afterwards as well. Our plastic surgeons do perform lympha, which does help reduce the risk of lymphedema. I will say we did a review and found that lympha was not being covered on a consistent basis by our insurance carriers. So we have moved to providing patients a cash option for lympha, unfortunately. But if your plastic surgeons are able to perform lympha at the same time, that I think does help reduce the risk of lymphedema. And the other things I discussed with patients, range of motion, sensory deficits, and recovery time. People always have questions about how long is it going to take to get back to my normal activity. I always give them a generous time because it does usually take a little longer, especially for the range of motion and lifting and moving things.
Great. Next. So when we talk about the axillary lymph node dissection, the operative standards as they're listed, these are the key elements, focusing on identifying the anatomic structures for your level 1 and level 2 axillary lymph node dissection, because again, we don't want to remove level 3 lymph nodes unless they're clinically palpable or abnormal, as well as documenting if any Rotter's nodes are removed, and then making sure you remove a sufficient number of lymph nodes to appropriately stage the axilla, and identifying those nerves that were mentioned, the long thoracic, the thoracodorsal, medial pectoral nerves, as well as those intercostal brachial nerves. And then again, always making sure to leave a drain so that seromas don't build up and you don't delay adjuvant treatments. Next. So this is just a nice picture from Netter's Atlas for you all about the anatomy of the axilla, which you all are very familiar with. But again, just as Dr. Yao said, having that long thoracic along the chest wall, your thoracodorsal bundle, making sure you understand where you're dissecting, and especially, as she mentioned, with the large involved lymph nodes, or someone who's received neoadjuvant chemotherapy, or someone who's a redo axilla, the anatomy may be different. So taking your time and making sure you're really understanding the structures. Next slide. So again, make sure you identify the axillary vein, the latissimus dorsi, the pectoralis major, the serratus anterior, as well as the subscapularis. Next. Making sure that you don't typically remove those level 3 lymph nodes unless they're palpably abnormal, because it not only increases your operative time and your lymphedema risk, but it does increase the amount of blood that's lost during an operation, and there's been no improved disease-free or overall survival if you remove level 3 lymph nodes. With regards to the Rotter's nodes, those interpectoral nodes, they're not typically recommended to be removed, again, unless they're involved. And then making sure you remove a sufficient number of lymph nodes, which we have stated is a minimum of 10 axillary lymph nodes. Next. When we identify those nerves, this is just showing you where those nerves run and what they innervate. So if they are damaged, these are the things that can occur: scapular winging, limited shoulder elevation, weakness, atrophy. And so it's really important that you're paying attention to those nerves during your dissection. Next. And then when we talk about those intercostal brachial nerves that sometimes get in our way, those are those ones that are exiting through the chest wall and the intercostal and serratus anterior muscles, and then crossing into the axilla, providing that sensation to that medial and posterior upper arm. So warning patients about some paresthesias and things that can occur, especially if they need to be resected. And then that drain, always leave that drain so that seromas don't happen, so that we can get on to whatever additional treatments may be needed. Next. So as Dr. Miggins briefly mentioned earlier, this is for the axillary lymph node dissection for the COC standards, making sure that you document curative intent, your resection boundaries were performed, and then that you preserve vasculature. And if you did have to remove a level 3 lymph node, why you needed to do so. Next. So Dr. Yao, we know what we did in this patient, but had she been premenopausal, would that have changed your decision making?
I think a premenopausal woman might, again, decisions for types of surgery and reconstruction, and would we want to give more time for those sorts of decisions and possibly looking more to neoadjuvant chemotherapy route. That would probably be the main thing that I would be thinking. And it's very patient preference based.
Next. And that's it. So thank you all for listening to our first case. And now you get to hear about lumpectomy and sentinel lymph node biopsy. We'll take all your questions at the end. So please think of things, as this was definitely one of those difficult cases.
Thank you, Dr. Kilgore. So thank you to Dr. Hunt and the rest of the panel as we proceed on to case 2. Next. All right, so we have a patient, Ms. B. She's a 63-year-old female, and she presents with a self-palpated left breast mass. She has a history of hypertension, hyperlipidemia, and a family history of a mother with breast cancer at age 72. On physical exam, her BMI is 26. Her bra size, she reports, as a 36C with grade 2 ptosis. And In the left breast, she has a 4.5 centimeter firm mobile mass that's palpable. It's in the upper outer quadrant at 1 to 2 o'clock. She does not have any palpable axillary, cervical, or supraclavicular, infraclavicular lymphadenopathy. Next. Here you can see her diagnostic imaging. This is after she's had biopsy, as you can see the clip, but you see the diagnostic mammogram, 2 views here with a large mass in the upper outer quadrant, as well as the mass on ultrasound with the clip present there. Next. And she has a diagnostic MRI as well, and you can again see that large mass demonstrated in the upper outer quadrant with the signal artifact from the biopsy clip. Next. So on her ultrasound guided biopsy, she is found to have invasive poorly differentiated carcinoma, grade 3, ER 0%, PR 0%, HER2, IHC is 0, Ki67 of 70%. So this is a triple negative breast cancer, and it's staged as a clinical T2 and 0, M0 stage 2B. Next. So she does undergo genetic testing, as is recommended for all triple negative breast cancers, and that is negative. And so she is recommended and undergoes neoadjuvant therapy with paclitaxel, carboplatin, and pembrolizumab first, followed by doxorubicin, cyclophosphamide, and continuing the pembrolizumab per the Keynote 522 regimen. Next. So Dr. Hunt, how would you counsel this patient regarding her surgical options?
Hi, thank you. Yes, so I would tell this patient that she's very likely to experience at least a partial, if not a complete clinical response with that neoadjuvant therapy regimen. And therefore, I would think that she would be a good candidate for breast conserving surgery. At presentation, obviously that mass was pretty large, and I think it might be challenging to leave a reasonable cosmetic result with such a large tumor for upfront surgery. But as you stated, she would be most appropriate for neoadjuvant systemic therapy. And so that gives you a little time to assess response and to also consider, her surgical options. But I would certainly give her the option for breast conserving surgery as my first choice, but also talk to her about mastectomy if that's something that she prefers. But her genetic testing is negative, and so I would certainly counsel her that I think breast conservation is a very good option.
All right, next bullet. So what if on her imaging she had a satellite lesion about 1 centimeter medial to the main mass? Would this change your decision making?
Well, I think that's, it's a good question. I think that you would consider that multifocal disease since it's very close to the primary tumor, and I would probably want to mark that in some way, put a clip there so that I can be certain at the time of surgery that I assess that in addition to the primary tumor site. So yeah, I think that would be something to consider. But it looked like, based on the imaging you showed me, that she had unifocal disease on ultrasound, MRI, and mammogram. She's trying to trick me.
You are correct. I'm throwing some curveballs here. All right, next bullet. So here's another curveball. Let's say instead of a satellite mass, there was 2 centimeters of calcifications extending anteriorly from the mass. Would this impact your surgical plan, and how so?
Well, I think I would still consider breast conservation. As I said, as you know, she's very likely to have a good response to that chemotherapy regimen, at least a partial response. And so I think she would still be a good candidate for breast conservation, but I would certainly want to include those calcifications in the surgical resection, as they may be ductal carcinoma in situ or potentially additional invasive disease. So I would try to make sure that I included that area in the resection at the time of lumpectomy.
Yeah, and I think that's a very important point to highlight, that sometimes those calcifications are still present at the end of therapy and should be resected. Next. So let's say there were two separate sites of cancer, so one in the upper outer quadrant and one in kind of the inferior breast at 6 o'clock, and both were deemed to be triple negative breast cancer. Would you still consider breast conservation surgery?
So, in this setting, probably not, because she's having neoadjuvant chemotherapy, and we really don't have a lot of data about treating multiple ipsilateral breast cancers after neoadjuvant chemotherapy. Certainly, we have recent data from the ACOSOG Z11102 trial, but that was in patients with upfront surgery. And so I don't think that, standard of care right now would be to consider someone like this for breast conservation.
And for the audience, we do have references at the end of the presentation for all of these trials. Next, please. So she completes her neoadjuvant therapy, as we stated earlier, and undergoes imaging afterwards. This is her diagnostic mammogram. And what you see is the biopsy clip there, but really no residual mass. This appears to be a complete clinical response, and the ultrasound also demonstrates that there is no regional nodal adenopathy seen. Next, please. And the MRI also shows a very favorable response, and you just see that artifact from the clip there. Next. So now, how would you counsel this patient given an excellent response on her surgical options?
So again, I think she's a good candidate for breast conservation. And, usually the way that we do that surgery is to try to target the biopsy clip and any residual radiographic abnormality, which from the imaging you showed, it doesn't look like there's really any residual abnormality, but certainly would localize that area of the clip and the primary tumor site for resection. And then also counsel her regarding sentinel lymph node biopsy at the same surgery.
Okay. Next. So again, what if the imaging had shown those persistent calcifications measuring 2 centimeters that had originally extended from the mass? Would you resect those?
Yeah, I would. And usually when you have a distance like that, you might consider doing some bracketing. So maybe putting 2 localization devices, one at the site of the biopsy clip, which was the primary tumor site, but then also one at the most anterior portion of those calcifications to make it a little bit easier to be sure that you've targeted that whole area for resection.
Okay, next. And let's say the tumor had not responded well to therapy and she still had a residual mass. How would you counsel her in that situation?
Yeah, unfortunately, we know that patients that don't respond to the neoadjuvant systemic therapy have a worse outcome overall. But I think that as long as you could still do a lumpectomy with a reasonable cosmetic result and achieve negative margins, that you could still consider that as treatment for her. As we talked about a little while ago, even up front, she might have been a candidate for breast conservation, although that's pretty large lumpectomy. So I would have to look at what her overall expected cosmetic outcome would be, and she would likely need, some local tissue rearrangement and probably a contralateral mastectomy as well, because with the tumor being that large and not really responding to therapy, that's going to change her breast size quite a bit. And of course, she'll need radiation therapy afterward. But I wouldn't necessarily go straight to mastectomy unless that's something that the patient wanted. The other consideration is, if she would be a candidate for a clinical trial. Obviously, the regimen that you gave her is, I think, pretty much standard now for triple negative breast cancers, but it's possible that she might be a candidate for a clinical trial considering her poor response to the systemic therapy.
Excellent. Next, please. So Dr. Hunt highlighted many of the key elements of the operative standards. And so this one is actually on partial mastectomy. And there are 5 critical elements. Tumor localization, as shown here, can be done in a multitude of ways. Initially, it was always wire localization, but now there are a number of non-wire alternatives on the market. And as you can see, it's very important for those patients who have non-palpable lesions, or for example, in this case, where they've had such an excellent clinical response and no longer have a mass that's visualized. So again, it's really critical, but up to the surgeon as to which localization device they may choose. Next. So then tumor resection is another critical element. And this is the idea that all gross disease is resected to microscopically negative margins. And the idea is that, especially for patients where you're doing upfront surgery, that the tumor is resected without violating it, ideally, and microscopically negative margins. It depends a little bit, but if you're talking about invasive carcinomas, typically the Society of Surgical Oncology, ASCO and ASTRO guidelines recommend no ink on tumor. In terms of intraoperatively, it is recommended that specimen imaging be performed. First of all, this is to verify that the correct target has been removed, and that can be by actually demonstrating the presence of the biopsy clip as well as the localization device, if that has been used. In this case, you see a biopsy clip and a seed there. And then it is recommended to perform 2-view 90-degree orthogonal images on specimen radiograph, and that can allow the surgeon to identify if there are any close margins that perhaps need to be excised intraoperatively. And then specimen orientation, and this is very important. This can be done by the surgeon in the operating room, either by using sutures, ideally in 3 locations, or by painting or staining on the 6 sides, or a combination of both. And this allows the pathologist to know anatomically what the position of the specimen was in relation to the breast, and that can allow for appropriate evaluation and assessment of the margins. Next, please. And so the 5th critical element is clip placement for radiation targeting. And in the Operative Standards Volume 1, this is really important for patients who are getting some sort of oncoplastic reconstructive technique, whether that's a local tissue rearrangement or mastopexy. And the evidence supporting that has shown that sometimes a tumor bed may move. And so by placing surgical clips, this can facilitate not only whole breast radiation, but also partial breast radiation from a radiation oncology standpoint. Next, please. So Dr. Hunt, talking about the axilla now, what is your approach to the axilla for a patient who is clinically node negative and has received neoadjuvant systemic therapy, such as this case?
Yes, thank you. So, several years ago, there were debates about should you do the sentinel node before the chemo or after the chemo. And I think that's pretty well settled now that the sentinel node biopsy can be performed after the chemotherapy, and it can decrease the extent of necessary surgery, but also it provides excellent prognostic information. So the nodal status after chemotherapy is highly prognostic and can help with treatment planning. Identifying residual disease after chemotherapy is important. As you know, there are additional adjuvant therapies that may be recommended. So I think sentinel node biopsy after chemotherapy would be the optimal approach for this patient.
Next. And so sentinel lymphadenectomy or sentinel lymph node biopsy is one of the other operative standards, and actually is the Commission on Cancer's Operative Standard 5.3, as Dr. Miggins had mentioned earlier. And so there are kind of 4 elements here that we need to discuss. First is actually the technique for injecting the localizing tracer dye. Studies have not shown that either a peritumoral or a periareolar injection site is superior. So either can be used and identify the sentinel lymph nodes, and that's really per the surgeon. Next, it's recommended that there should be a pre-incision evaluation of the drainage pattern. And so this can be done by using a probe, such as shown in this photograph, to identify, for example, the hottest spot of radioactivity, if that is the localizing tracer that is used. And this can facilitate a more minimally invasive sentinel lymph node biopsy. Next. And so then, of course, it's important to identify all of the sentinel lymph nodes present, and that's based on the localizing tracers of dyes used. If there's only one, such as radioactive dye, then looking for all of the hot lymph nodes, or in this case, if there's also a blue dye used, looking for blue nodes as well. Now, there is also a key element about palpating the axilla, and if there are any dominant palpable lymph nodes that are identified, those are also deemed to be sentinel lymph nodes and should be removed. And finally, techniques to limit seroma formation during this procedure. There's no one procedure that has been determined to be beneficial in limiting seromas. And so the Operative Standards Volume 1 recommends that surgeons decide what technique works best for them in terms of limiting seroma formation. Next. And so, as I mentioned, this is standard 5.3 that Commission on Cancer sites are required to be compliant with. And it's really based on the documentation in the operative report. And so the required elements there are that this is for curative intent, which tracer or tracers are used. Is this being done in the upfront surgery setting or in the neoadjuvant setting? Have all of the sentinel nodes been removed? And then also, if there are any lymph nodes that are clipped, have those been removed? Next. So Dr. Hunt, do you routinely perform frozen sections intraoperatively on sentinel nodes?
Well, that's a great question, because in the past, I think it was our practice to do frozen section on these sentinel nodes. And if you found something in the nodes, then to do a completion node dissection at that time. But I think we're moving away from that for a number of reasons. But just to briefly mention, you know, this patient had clinically negative disease based on ultrasound, and MRI also did not show any abnormal nodes at presentation. And she had a very excellent response in the breast primary. So it's unlikely that she is going to have nodal positive nodes after an excellent response in the primary and clinically negative nodes at initial diagnosis. So I would counsel her that her likelihood of having positive nodes is very small. We might want to do an approach similar to what Dr. Yao mentioned earlier with lympha or something of that nature if she needed a lymph node dissection. And also, I think it's hard for the radiologist to, the pathologist to identify very small foci of disease intraoperatively. And so for all those reasons, I think we're moving away from doing intraoperative frozen section.
Okay, next. So here's another curveball. What if she had actually been staged as clinical N1 with one abnormal lymph node and axillary ultrasound that was biopsied positive? How would you approach this situation?
So I knew you were going to ask this. So this type of patient, well, first of all, you know, I would want to be certain that that abnormal node was biopsy proven disease at diagnosis, because as people may have noticed on her initial mammogram, you could see some axillary lymph nodes on the mammogram, and they're likely to be reactive from the recent biopsy. So the ultrasound, I think, is more sensitive and more specific with respect to that. So I would want to make certain that it was biopsied and that a clip was placed, because in my practice, I would target the clipped node in addition to performing a sentinel lymph node at the time of surgery. And the fact that she only had one abnormal lymph node and she had a good response in the breast would make me more likely to want to use this approach, which is called by some targeted axillary dissection. And I think Dr. Yao also mentioned that earlier, that that approach would be something I would consider for someone with limited nodal disease at presentation like this individual.
Excellent. Next, please. So to round out her course, she did undergo a partial mastectomy with seed localization and a sentinel lymph node biopsy with dual tracer technique. The biopsy clip and seed removal were verified on that partial mastectomy specimen radiograph. And she actually had 3 sentinel lymph nodes which were retrieved, all negative for metastatic carcinoma and frozen section. Her surgical pathology demonstrated no residual carcinoma in that partial mastectomy specimen. There was area of fibrosis consistent with the treated tumor bed. And the 3 sentinel lymph nodes were, again, all negative, confirmed on final pathology. So she was a YPT0N0, a pathologic complete response. Next. So just some final questions, Dr. Hunt. If she had had residual disease in the breast on surgical pathology, what would you consider an adequate margin?
That's another great question. I think the margin data that, or paper that you mentioned previously, was based on patients having upfront surgery and also having whole breast radiation. And as the field is changing, and we're using more neoadjuvant systemic therapy and other radiation techniques, it's a little hard to know what the appropriate margin should be. But there are certainly publications suggesting that no ink on tumor should be appropriate in this setting. If it's DCIS, then generally we try to achieve a 2 millimeter margin, similar to the upfront surgery patients. So again, a little controversy here, but certainly we want negative margins around the primary tumor site.
Okay. Next. And what if there had been a positive sentinel node, and does the size of that metastasis matter?
Well, first of all, based on standard practice right now, positive sentinel lymph node after neoadjuvant chemotherapy is considered, a patient should be considered for an axillary lymph node dissection. That would be standard of care. As you know, there's a trial that was led by the Alliance in Clinical Trials in Oncology called the A011202 trial. And this is a trial where patients who have initial node positive disease that's proven on biopsy undergo, that have a good clinical response, undergo sentinel lymph node biopsy after chemotherapy. And if they have a positive sentinel lymph node, they were randomized to either have an axillary lymph node dissection with standard radiation versus radiation and no further axillary surgery. So that trial has been completed, is no longer accruing patients, but we're still waiting the results. So we don't have, data to support omitting axillary lymph node dissection in the setting of a positive sentinel lymph node. In terms of the volume of disease, I think that it is important, ITCs versus micrometastasis versus macrometastasis. And we do have nomograms that suggest that you can use them to determine what is the likelihood of residual disease remaining in the axilla after a sentinel lymph node biopsy.
Great. Next. And so finally, we're seeing more and more patients who are now on immunotherapy such as pembrolizumab, and there's definitely a risk of immunotherapy-associated endocrinopathies. Do you do anything specific when you're managing these patients preoperatively, given that risk?
Well, certainly screen them for any signs of thyroid disease, adrenal insufficiency, and things of that nature. Generally, the patients will have some type of symptoms, or in our standard preoperative workup may have some abnormal laboratory studies, but there are some guidelines that have now been published by different groups ASCO and others in terms of what you should be looking for with respect to toxicity related to the immunotherapy in these patients.
Okay, next. Thank you. That was an excellent discussion, Dr. Hunt.
Thank you.
Next.
Well, thank you to Dr. Yao, Dr. Hunt, Kilgore, and Dr. Singh for the presentation of these complicated clinical scenarios. I think we find ourselves faced with these types of challenges daily in our clinic, but also thank you for the detailed illustration of how we not only think about these, but how we go about performing the key and critical elements of the cancer standards, which are sentinel node dissection, partial mastectomy, total mastectomy, as well as axillary lymph node dissection. Let me just check to see if we have any questions from our panel guests, or not just our, sorry, our attendees. I don't currently see any questions in the chat box. Any parting comments from our panelists?
Well, there's a separate panel called questions where all the questions will be, not in the chat. And I don't know if Chantel or somebody else on the webinar can look at, I just can't imagine there are no questions with these types of cases.
Here.
But
well, some of them I believe have been answered. For example, about frozen sections, that was answered previously.
I got a message sent to me. Someone was asking more, Dr. Yao, about lympha. And you mentioned that, you know, both your institutions, Dr. Hunt, Dr. Yao, offer lympha. We do as well at the University of Kansas. But people were asking me, how do you get that covered? You mentioned cash pay. What are other sites supposed to do? What is, you know, some of our national breast committees doing to help get lympha covered moving forward?
I think that's a great question. I'd love to hear what everybody has to say. I had heard that there were some coverage depending on the site across the country, but for the most part, we have not seen great coverage of lympha. So I would love to hear from the other panelists, what have you been doing to try and get lympha covered, or have you been successful at that?
I know with our program, you know, we bill insurance, and then if it's not covered, we negotiated with our health system to eat the cost. Initially, it was cash pay, like you were mentioning, like a plastics, you know, cosmetic, but then we discussed how that was discrepancy of care for those who can't afford it. So that's been a really very intense, long, year-long discussion with my institution to try to get them to eat those costs, but still billing it. And every once in a while, we have a payer that will cover it, and I'm not sure why.
Yeah.
But yeah. I don't know, Dr. Hunt, I know you guys just do it on everyone, and it, you know, MD Anderson takes care of it usually. But what do you know on a national level? Is there any movement towards getting this better covered and getting those ICD-10 codes?
Well, I know that the American Society of Breast Surgeons is always really active in this area of trying to make certain that we have the appropriate codes for billing for patients. And I know that, you know, we have so many different insurance types that I can't really say off the top of my head which ones are approved and which ones are not. But we always try to get approval for the procedure before we do it. And so, you know, I think Puneet or Makisha, do you know anything about the ASBRS work in this area?
I'm not familiar of what's been going on currently.
But I know it's an area of interest, and so stay tuned and check out the website. And certainly it's an area that is starting to be more data rich, you know, showing that doing this procedure does lower lymphedema rates. And we know that lower lymphedema rates are associated with improved quality of life. And so we do have the Alliance trial, which Suzanne Klimberg was the PI, using axillary reverse mapping, and then any type of lymphatic reconstruction that your institution was used to using. And that was a prospective randomized trial, as you know. That has completed accrual, so we'll wait the results of that trial. But there are a number of other trials that have been recently published showing that lymphatic reconstruction after axillary lymph node dissection can reduce lymphedema rates and improve quality of life.
Thank you for that. I do see a question here regarding the clip, and I believe that the person is referring to the clip node that was part of your case, Dr. Hunt and Dr. Singh.
Could you read out the question? I'm sorry, I'm not seeing
the question. It was just, can you explain the clip?
Dr. Hunt, would you like to take that?
Sure. So I think this is an area of controversy. It depends on institution to institution, but certainly at my center, when we find an abnormal node on that initial ultrasound and we biopsy it, we like to place a clip there so that when we go back to do the axillary surgery after neoadjuvant chemotherapy, we can be certain to retrieve that initial biopsy-proven node. What we found and has been published by many other centers as well is that if you're doing sentinel lymph node biopsy alone, even with dual tracer, about 25% of the time you will not retrieve that clipped node. And so we like to make certain that we can target that clipped node with some type of a localization device similar to what Dr. Singh was describing for the breast primary after neoadjuvant chemotherapy or upfront surgery.
And do you have a preference for what you localize that lymph node with? Do you use a wire, a seed, a mag seed? You know, there's so many different localizing devices out there.
Right. When we first started doing that, we did use wires, but you know, that's really, I think, technically more challenging and uncomfortable for the patient. So we do now use the seed technology. We used to use radioactive seeds, but now we have other types of seed devices. And so right now we have multiple different types of devices that we can use. So I think it's surgeon preference. And so whatever the surgeon prefers, generally what you're using for the breast primary to localize it, we use the same type of seed to localize the clipped node.
Okay. We just use radioactive seeds. We use that both in the breast and the axilla. And it seems to work very well.
Yeah, we did that for many years, but we moved away from the radioactive seeds just because of the administrative burden associated with it. So,
the regulatory paperwork and all of that, yes. But it is fairly cheap, I must say.
Yes, so. You're right, and it works well. It works very well. So.
Okay, we are a little bit over time, but there are a couple of more questions if our panelists don't mind entertaining them. Just for everyone listening, there still will only be one CME credit, even though we are going a little bit over, but we do appreciate your attentiveness. Dr. Singh, I believe you have a question from the audience. Thank you.
So one of the audience members asked for that second case, if the patient had undergone mastectomy instead of breast conservation surgery, would you do a frozen section on the sentinel lymph node? And I think, as Dr. Hunt had mentioned, you know, the tide is turning a little bit on doing frozen sections intraoperatively for many reasons. And so I would say that no, I don't think that would necessarily change based on the type of surgery and management, such as if there were a positive sentinel node, whether you've done mastectomy or breast conservation surgery after neoadjuvant therapy would still be the same to do a axillary lymph node dissection at this time.
I think I do frozens in the neoadjuvant setting if I'm suspecting that the node is going to be positive, the patient's not going to have lympha, and I'm a little worried that it's going to be difficult to get the patient back in for a second surgery should they need it based on transportation, home situation, etc. Those are the sorts of situations where I might do a frozen section in the operating room.
Yeah, and absolutely. That's what makes it complicated with respect to, you know, patient care. We want to follow the standard practice. We want to give that to our our patients, but we know that there are many things that will come into play in that decision making. And so it is important, I think, like you said, to discuss all this with the patient before the surgery so that they know what to expect as part of the intraoperative approach.
Yes, because recovery from these surgeries is a lot, and patients really need a lot of resources at home to help them recover. So doing the surgery is one thing, but the recovery is a whole nother thing that you need to ensure that patients are able to do.
Dr. Hunt, there's a question here regarding the nomogram that you mentioned. Specifically, does that nomogram include neoadjuvant patients?
So we do have a nomogram at our center that's available online for neoadjuvant patients. It is a bit dated, and so it does not include, it does not include the recent immunotherapy Keynote 522 regimen like Dr. Singh described. And so we are in the process of updating that now, but there may be some other nomograms out there available as well.
Thank you. And then Dr. Singh, you have another question from the audience?
Yes, so this one should be a quick question. Do you have a preference for methylene blue or lymphozurin blue for the sentinel lymph node biopsy, and why? I will say it's, I think, institutional practice. Our institution uses lymphozurin blue dye, but in my prior practice, it was methylene blue. So I don't think that I have a specific preference personally. I don't know if the other panelists do.
We use methylene blue. We do dilute it. We do a cc of methylene blue with, 0.5 cc's of methylene blue with 4.5 cc's of actually D5W. I do think the lymphozurin maps better than the methylene blue, but the lymphozurin is a lot more expensive and it is associated with allergic reactions. So you do have to be careful, and patients can have pretty severe allergic reactions. So we have moved to methylene blue. I think what helps with the mapping with methylene blue is the breast massage that you do. And I'm going to credit Dr. Jaskowiak, who's a breast surgeon at University of Chicago, for this technique that I stole from her. I hope she's not on this webinar, but she takes a blue towel, rolls it up, put some steri strips to keep it rolled, and then you use that as sort of a roll to massage the breast and go from the nipple all the way down to the axilla to encourage the dye to reach the lymph nodes. Puneet, you're probably aware of this technique.
Yep.
With working with Dr. Jaskowiak. So that really does help, though, I think, with the mapping with the methylene blue.
What do you guys think of the indocyanine green and using it with SPY for your dye for your lymph nodes?
I have no experience using that. I have not tried that yet.
We've been using that a lot, in patients that don't have an iodine allergy, and since they're going to already use SPY, a lot of our plastic surgeons do. It's no extra cost to the patient, so we've enjoyed that, not having that, because we use lymphozurin as well, so high cost. So we've actually been saving the patients money in that instance, but it is definitely a learning curve to use the indocyanine green. And have the SPY equipment in your small axillary incision. But
yeah.
I've been enjoying not having blue all over my field. So I was curious if any of you had been using it.
Okay, one last question, and this is a technical question in regards to a patient who's undergone bilateral mastectomy, and one of the breasts is a prophylactic mastectomy. Would you perform a sentinel lymph node dissection on the prophylactic breast?
Not in my practice.
No, I would not.
Okay, me either. Okay. Any other questions? I think Dr. Kilgore, Dr. Singh, I know that you all have been receiving questions. Do you have anything else that needs to be answered during this session?
Really quickly, I'll bring up one last one related to the clipped lymph node. So this is, what if the clipped lymph node is actually benign at the beginning and concordant? Would you specifically remove that clipped lymph node with your sentinel lymph node biopsy after neoadjuvant, I'm presuming?
I have not been
I would-
typically doing that.
No. So you're saying you have a clinical N0, the patient happens to get a node biopsy because something abnormal on imaging, and it turns out to be negative. And then they have neoadjuvant
I'm
therapy.
presuming.
They have
Right.
no lymph nodes that develop on exam. So do you remove that clipped node, or do you just go right to the sentinel node mapping?
Right.
Okay. So yes,
Exactly.
I just go right to the sentinel node mapping. I don't plan to remove
Yeah.
the clip node or target it or localize it.
Yeah, I do the same. And sometimes out of academic interest, I will radiograph the sentinel nodes just to see if it happens to be a clipped lymph node, which often it is. But no, I do not localize the node specifically to remove if I believe it's benign and concordant.
Yes, I agree.
Okay, well, in the interest of time, I think that we probably should end the webinar, but I do appreciate first all of our panelists for their clinical expertise and the great discussion. And again, to all of our webinar guests who have sent in so many questions in our chat. We will review these questions and try to distribute answers afterwards. But again, thank you all for your engagement and your attention tonight.